Hello, everybody. Welcome to our CCRN and PCCN Q&A session. And today we're going to be talking about acid-base balance and oxygenation. So while everybody's coming into our webinar, if you'd be so kind just to take a moment and put in the chat who you are and where you are from. City and state, that would be wonderful. I see some familiar names from before. Hello, Ethel. Welcome back for another webinar. Eileen, great to see you again from Philadelphia. Heidi from Cleveland, Ohio. Hello, Heidi. Welcome. Let's see. Who else in the chat? I think everybody's kind of shy today. So without further ado, let's go ahead and talk a bit about our Q&A for today. The one thing that I want to make sure that I get out right at the beginning is that if you find that this Q&A would be beneficial to your friends, anybody in your unit, please know that this webinar will be posted on YouTube once the video portion of it is made available. Sometimes it takes a little bit for the recording to be made available. And for those of you in attendance today, you will get a copy of the video emailed to you as well. So again, you won't be losing out on the information by any stretch. Hello, Kathy from Northport, Florida, currently in Fresno. Thank you for joining today. So let's go ahead then and get into our very first question. Let me see here. And then let me also mention that on YouTube, you can find my channel under K Hoppy Presents or at K Hoppy Presents. And I'd really appreciate it if you would take just a moment and subscribe on YouTube to my channel. I would really appreciate that. So here is question one of our Q&A for today. The best overall respiratory assessment parameter is, I will pull up the poll. Okay, so let's go ahead and move on to the answer here. I am getting some choices for ABG results. I am getting some choices for lung sounds. So let's take a look at the answer. The answer for this one is respiratory rate. If you think about it just for a second, the respiratory rate is really very much an early clinical indicator that something's going wrong, right? So we have all seen where we've gotten an ABG result back and we think, not bad. It's really not looking half bad. But yet we look at the patient and that patient is just chugging along in order to give us that ABG result. Same goes with lung sounds. You know, we can see a patient kick up on their rate and depth of ventilation before we start to hear crackles in the bases that spread or wheezing or whatever. So again, the best overall respiratory assessment parameter and the one that is early is the respiratory rate. Just basic respirations. Oops, whoop. I accidentally moved ahead there, so pretend like you didn't see that. Let's move on then to question number 2. You're caring for a patient who's intubated and mechanically ventilated due to ARDS. He is hemodynamically stable, and you receive the following ABG. So take a look at the ABG and tell me what your answer would be here. Just give you a few seconds for that. Okay, question number 2. The answer is an uncompensated metabolic acidosis. We can see that the pH is definitely in acidotic range. PCO2 is normal. PO2 is 70 with a SAT of 90%, and the bicarb is 14. Of course, bicarb normally 22 to 26. When the bicarb goes down, the pH is going to go down as well. Or I can say that the other way, that in a metabolic acidosis, we see that as the pH goes down, it's reflective of a lowering of the bicarb. Now, the one nice thing about both exams, whether you're talking about the PCCN or CCRN, is that neither exam asks you to identify a partially compensated disorder. So, on your exam, it is only going to say whether or not a person is compensated or uncompensated. And the best way to do that, of course, is just to take a look at the pH. Is the pH normal or not? If the pH is not normal, you know that you have an uncompensated something or another. But if the pH is normal and the rest of the gas looks out of whack, it doesn't look normal, then you know you have a compensated disorder. Then you just have to look further as to what that disorder is. So kudos to you guys here for question 2. Uncompensated metabolic acidosis is the answer. On to question 3, and I want you to think about this one before you answer. You are caring for a patient who's intubated and mechanically ventilated, same patient, literally. They have ARDS, they're hemodynamically stable. This is just a cut and paste from the previous question, but I've given you a little bit more data on this one. I've given you an anion gap of 14. Now, the question asks you the most common cause for this type of acid-base imbalance in the critical care setting is, and I will go ahead and pull up the poll. Give you about 5 or 10 seconds to figure that one out. Okay, let's talk about this. Let me pull up the answer. The most common cause for this is D, diarrhea. Now, what are some clues here? Okay, because initially the question always comes about, well, wait a second here. We have a person that has a bicarb of 14, that's low, they're acidotic. pH, which is also low, that's acidotic. So given that, why isn't it tissue hypoperfusion? Because, I mean, after all, we have a metabolic acidosis here. We have a critically ill patient. Yes, that's true, but a couple of things. Number one, we said he's hemodynamically stable. Okay, that's a good thing. Tissue perfusion or tissue hypoperfusion would have affected the anion gap. And the anion gap is another piece of information that I am adding to our question here, just to make you think a little bit. So we're going to get into right now, we're going to talk a little bit about what anion gap means, and then we'll come back to these answers and talk about why it is that the answers that are not correct, and the one that is correct, why it is correct. So the anion gap, probably the best clinical application or utility of the anion gap is to determine an etiology of a metabolic acidosis. So if I were to ask you something kind of strange, like kind of out there, like say you had a patient that said to you, nurse, I have always had this desire to become metabolically acidotic. How could I become metabolically acidotic? Now, at first, you're going to think, whoa, now that is strange. And that person is really asking a bizarre question. But then, you know how sometimes people will ask you a bizarre question and it will pique your interest? Like, if somebody was set out to become metabolically acidotic, how in the world would they do it? Well, they could pull it off by one of two mechanisms. One mechanism is they could cause or have an overall gain of acid in their body, an overall acid gain. All right. So, yep, that could make me metabolically acidotic. Well, another thing that could make me metabolically acidotic is if I had an overall bicarbonate loss. So, again, a metabolic acidosis is due to acid gain or bicarb loss. And if you were to look at the etiologies of a metabolic acidosis, what you would see is that those etiologies, they fall under those two main categories, one or the other. Either that etiology causes an overall acid gain, or the etiology has caused a bicarbonate loss. So think of the anion gap as a tool. Normally, the normal anion gap is 8 to 12. If potassium is included in that equation, then the normal goes up to 16. So what we're doing to determine an anion gap, and really nurses don't even have to determine an anion gap anymore. That's done as part of the lab report that you get, is we're taking our body's primary cation, which is sodium, right? When you think about sodium, you think about something that has what? 135 to 145 milliequivalents. So that's a big player. That's our big positive ion. Now, potassium, yes, I agree. It also is a positively charged ion. However, potassium has a very small quantity in the serum, right? So when you think about a normal potassium, you think about what? 4 versus sodium, 138. And so a lot of times for the anion gap calculation, the potassium is left off. But if you include it as part of the equation, then the normal will go up to 16. It is left off here in this slide. So we take our body's primary cation, which is sodium, and we subtract from it our body's primary anions. And our body's anions are the ones that carry a negative charge. And so that's where we have chloride and total serum CO2. So when we add those up, because they're both negatively charged, we add them up and we subtract them from sodium. That's where we get our anion gap. And so when we talk about the players of this equation, sodium, potassium, and total CO2, which a lot of times people look at total CO2 and call it bicarbonate. And that's, I guess partially correct, but it's not really the precise name of the lab value. Total serum CO2 represents this thing that we call bicarbonate. The total serum CO2 represents the ways in which carbon dioxide travels in our body. We know that there's a little bit of dissolved CO2 in our plasma. We also know that there is CO2 that travels in our body in the form of carbonic acid, a little bit. But the majority of the carbon dioxide, and by the way, I'm not talking about PCO2. I'm not talking about the stuff that's, exhalable. That's a partial pressure of a gas. I'm talking about carbon dioxide that is the end product of normal day-to-day metabolism. And our body produces about 50 milliequivalents of it that it has to get rid of every day. So going back to total serum CO2, the majority of the carbon dioxide travels in our body in a chemical conversion reaction to form bicarbonate. So most of the serum CO2 travels in the form of bicarbonate. And so that's why we say that the total serum CO2 is reflective of our bicarbonate level, because that's how metabolic CO2 travels. So we know then that when our metabolic total serum CO2 goes down, we know that our bicarb is going down, right? And if our bicarb is going down, we know that we're becoming more acidic. So when we look at our chemistry profile, we look to the total serum CO2 to be representative of our pH. And as it goes down, the body is becoming more acidic. And as it goes up, the patient is becoming more alkalotic. Now, how does it relate to this anion gap? We'll go back to what we said before. We said that if somebody is going to have a metabolic acidosis, that acidosis is going to be because of one of two causes: acid gain or bicarb loss. So it's this equation, the anion gap, that helps us be able to differentiate between a metabolic acidosis due to acid gain versus a metabolic acidosis due to bicarbonate loss. And so we say then that if somebody has a metabolic acidosis with a normal anion gap, the reason for that metabolic acidosis is bicarbonate loss. Whereas if we have a patient that has a metabolic acidosis with an increased anion gap, then it's not because of bicarb loss, it is because of acid gain. So I'm going to go ahead then and go back one slide to question 3. Now notice, all of us can agree that we have a metabolic acidosis here. There's no question about that. So then we say to ourselves, what's the cause of that metabolic acidosis? Is it acid gain or is it bicarb loss? And here, take a look. Our anion gap is 12. And that's a normal anion gap. So we have a normal anion gap metabolic acidosis. So it's not due to acid gain. If it was tissue hypoperfusion, we know that we would be gaining acid. Acid in the form of what? Lactic acid, because of tissue hypoperfusion. So when you look at these factors here, we're going to see acid gain. However, when we talk about diarrhea in the critically ill patient, this is where we have bicarbonate loss. So bicarb loss is the key here to a patient that has a normal anion gap metabolic acidosis. All right, I'm going to go ahead then and move on. I'm going to just take a second quick and go over to the chat, see if anybody... Okay, I don't see any questions related to this. So let's go ahead and go to question 4. This is another one that's really going to tap into your gray matter in a big way. And this has to do with the oxyhemoglobin dissociation curve. And what it asks is a shift to the left of the oxyhemoglobin curve or oxyhemoglobin dissociation curve reflects what? Take a few seconds and think about this. Okay, I'm going to go ahead then and pull up the answer. And the answer is C. Increased affinity between hemoglobin and oxygen, resulting in a decrease in O2 unloading to the tissues. Now, we need to spend a little bit of time talking about the oxyhemoglobin curve, because the minute I bring this up in my CCRN review courses, I see all kinds of blank stares in the room like, oh my gosh, is she really going to explain this? Well, one thing I find about critical care nurses, which is true of me as well, and that is you have to explain why it is that knowing something is important and how it applies to the guy in the bed. Once you can tell me how something applies to the guy in the bed and helps to raise the bar on my clinical practice, I have a better chance of remembering it versus, kind of material that nurses call fluff sometimes that they can't apply to the person in the bed. So let's apply this because it is really critically important. Now, when we talk about oxygen transport, of course, we know that the majority of the oxygen in the blood is combined with hemoglobin. And you see this here. You see the majority of the oxygen in this little segment of bloodstream is combined with hemoglobin, and only 2% of it is dissolved in the plasma. We also know that hemoglobin has a very reversible relationship with oxygen. So let hemoglobin be the magnet and let oxygen be the nails. And so we can see, for example, in the lungs, hemoglobin has a very high affinity for oxygen. And so we see that in the lungs, hemoglobin will pick up oxygen just as we would anticipate hemoglobin doing. We would want that. At the tissue level, we expect the affinity to drop. And the reason why the affinity between hemoglobin and oxygen drops at the tissue level is because of local tissue acidosis, which is the end product of normal everyday metabolism. So hemoglobin, then the affinity decreases and oxygen is released to the tissues. These are all things that we want. So increased affinity in the lungs and then decreased affinity at the tissue level. Now, here is the oxyhemoglobin dissociation curve. And what this curve looks at is it looks at the relationship between arterial saturation and PO2. And we're concerned about this curve and the movement of this curve either to the left or to the right. So let's take a look here. Now, from little on, now I've been in nursing for 40 years. So it used to be that we didn't even have pulse ox. Pulse ox was not even an option. So we were doing ABGs on people like crazy until pulse ox came out and it gave us a whole lot of information such that we didn't need to be poking people all the time for ABGs. We could look at the patient's oxygenation by looking at pulse oximetry. Now, take a look at this curve, the oxyhemoglobin curve. It looks really kind of like a sloppy S, where we have the plateau portion of the S up on top. And then, it kind of drops off from there. It drops off from the plateau portion downward. And so, what I want you to really hone in on here is I want you to hone in on the fact that there's a direct relationship normally between a 90% saturation and a 60 PO2. Again, a normal relationship between a saturation of 90 and a PO2 of 60. So I want you to think about your clinical practice right now. And I want you to think about the fact that when you put a patient on a pulse ox, for most patients, again, emphasis on the most patients, for most patients, we will accept a saturation of at least 90% or greater, right? I mean, we'd like it 92, and for other patients, we'd like it a little bit higher. And then we know that there are some patients, like our chronic CO2 retainers, our 50/50 club members, right? Our COPD patients with 50 PO2 and 50 PCO2. Then we will allow a little bit lower, like 87, 88% as their baseline. But for most people, 90% saturation or greater is the bare minimum. because that equals a PO2 of 60. Now, with that in mind, I'm going to move on to the next slide. Take a look here. We have the normal curve, which is that 90-60 relationship, which we just went over in the previous slide. Now we see when the curve shifts to the left or shifts to the right. The conditions that cause it are listed for you here, but more importantly than memorizing etiologies is understanding the concept first. So when we talk about a shift to the left, and that is to your left as you're looking at this slide, when the curve shifts to the left, what we see is that for that same PO2 of 60, the patient's going to have a higher saturation. That means that there is hemoglobin that is hanging on so tightly to oxygen. That means that the affinity has increased. So when the hemoglobin curve, oxyhemoglobin curve, shifts to the left, there is a greater affinity between hemoglobin and oxygen. So hemoglobin is holding on to its oxygen much more tightly. Well, what does that mean for the guy in the bed? What that means for the guy in the bed is that the tissues are not getting oxygenated. So hemoglobin is not releasing the oxygen normally. And so if, for example, you are a patient that has, let's say, pre-existing cerebral vascular disease, now you are at higher risk of stroke because of this shift to the left of the oxyhemoglobin curve. If you are a patient with cardiovascular disease, when the curve shifts to the left, you are most likely to have angina or chest pain, MI, because of lack of tissue oxygenation. So what you remember about a shift to the left, think left, lousy. We don't get tissue oxygenated. However, you get this pretty looking pulse ox. You get a pretty looking pulse ox and a not so good looking patient. They don't look like they're perfusing very well. So we know when we have a pretty looking pulse ox and a not so pretty looking patient, we've got to get a full ABG. That would be one of the clinical indicators to get a full ABG. So now let's talk about the things that can shift that curve to the left. We have decreased temp, so hypothermia. And what might be going through your head at this point is, whoa, wait a minute here. In my unit, in patients that have cardiac arrested with ROSC, we go ahead and employ things like targeted temperature management, where we bring down their core body temperature. Aren't we adding, harm to injury by doing that? Well, I want you to think about a standing order set for therapeutic hypothermia or targeted temperature management. Don't you usually find, and you will find, that our goal for our SpO2 is higher? We have a higher saturation because this patient's tubed and on a ventilator. So we have a higher saturation target to make up for the fact that we're cooling the body's temperature. So you see, we know that the shift to the left is going to happen. So we counteract that by increasing the saturation through mechanical ventilation. Also, decreased levels of 2,3-DPG. What in the world's that? 2,3-DPG, 2,3-diphosphoglycerate, is, I want you to think about it as the stuff found on the red blood cell surface that actually kicks off oxygen to the tissues. Think about it as a big boot that kicks the oxygen off the hemoglobin into the tissues. We like 2,3-DPG. It's a good thing. Now you might be saying to yourself, what in the world would cause a patient to have decreased levels of 2,3-DPG? Well, one key one that I want you to keep in mind is the patient who is septic, or the patient who is becoming septic. Now, I want you to go back to the bedside and I want you to think about this for a second. Isn't it true that when you look at the patient and you're assessing their oxygenation and you see a pretty looking pulse ox, but you have a patient that just is not looking like they're oxygenating? Don't you ask yourself, "Ooh, I wonder if they're getting septic. I wonder if they're headed down that septic pathway." Because if you're not saying that to yourself, that is one of the diagnoses that should certainly be hitting your radar. So in sepsis, we see decreased levels of 2,3-DPG. We also find that high altitudes can cause decreased levels of 2,3-DPG. And in fact, people that live at high altitudes over time their body will continue producing more 2,3-DPG. So that's why people find that when they go to high altitudes, they have trouble breathing because we don't have the hemoglobin readily kicking off oxygen to the tissues as it had before. Also, alkalosis. So I want you to think about this person that is becoming alkalotic for any reason. The patient that becomes alkalotic for any reason, pH gets higher and higher and higher, and now we approach emergency level. 7.6 is never a good day. So when you're up in the 7.5s region, you've got to think that that hemoglobin is holding on to oxygen like craziness, and it's not releasing it to the tissues properly. So if you have somebody that has an NG tube post-abdominal surgery, and they're putting out buckets and buckets and boatloads of NG tube drainage, you got to be thinking to yourself, whoa, this patient has a risk factor for developing metabolic alkalosis. Metabolic alkalosis affects oxygenation because it shifts the curve to the left, making hemoglobin hang on to oxygen more tightly, which is not a good thing. Also, carbon monoxide will do that as well. That's why we have to use hyperbaric oxygen in patients with carbon monoxide poisoning. Now, a shift to the right, think of everything I just said and turn it around. A shift to the right is caused by acidosis. What's going to happen with a shift to the right is that affinity or attraction between hemoglobin and oxygen will be reduced, and therefore hemoglobin will readily kick oxygen off into the tissues. And so you may have heard a physician say something like, well, I'd rather have my patient be a little bit acidotic than alkalotic. It's easier to treat. From a tissue oxygenation standpoint, it's better than a shift to the left and alkalosis. Fever will cause a shift to the right, increased levels of 2,3-DPG. As we said, people that live at high altitudes put out a whole lot of 2,3-DPG, and so do patients that are chronically hypoxic, patients who chronically retain CO2. So you take our patients that we call 50/50 club members, and I can tell you they are 2,3-DPG producing machines. And that's why it is, guys, if we have one of these CO2 retainers, 50/50 club members that are tubed in on a ventilator, if they become alkalotic, it's really a bad thing for them because they're used to every day walking and talking and shopping at Target with their curve shifted to the right. So if we start to pull it left and hemoglobin starts holding on to oxygen more tightly, you're going to have a patient that A, is not going to get off the vent. And if they're off the vent, they're going to be in trouble. So some important things to keep in mind. So acidosis is a factor causing that shift to the right. All right, so let's move on. Question number 5. Now we have a patient on a vent with the following blood gas, and what would be your initial intervention? Give you about 5 more seconds to look that over. Okay, let's go ahead and pull up the answer. We need to focus on that bicarbonate. That doesn't necessarily mean administering bicarbonate. We have to focus on the metabolic piece of this. So let's start from the beginning here. This patient's pH is 7.14 and the patient's bicarbonate is 9. So we know that they have a metabolic acidosis. In compensation for that, the patient is hyperventilating, or maybe we are hyperventilating them, which at this point is totally appropriate, because if the patient can't kick up their rate and depth of ventilation in order to try and counteract a metabolic acidosis by producing more of a respiratory alkalosis, if we can't hyperventilate in the face of metabolic acidosis, then in a tubed patient, we have to change the ventilator settings in order to do that for the patient. So we would not decrease the ventilator rate. We would not decrease the tidal volume. There isn't anything that would cause us to increase the FiO2. Okay, our SAT is 90%. PO2 is 87, but we have to really focus on asking ourselves, what kind of patient is this and why is the bicarb 9? Is the bicarb 9 because the patient's shocky and we need to give the patient fluids and an inotrope in order to increase perfusion, or fluids and a vasoconstrictor, or just one of the above, depending upon their pressure and hemodynamics and all the other data that we gather? Could that be a cause? Or could this be a person with diabetic ketoacidosis? And this patient, where we need to go with this patient, is fluids and insulin, right? Because if we can get insulin working and carry glucose into the cell like it should be and work on ketogenesis, remember, ketogenesis is treated with insulin, right? That's how we treat ketogenesis. Is insulin is going to do what? Insulin is going to help carry glucose into the cell. The cell gets fed. It stops breaking down fats in order to, as an end result of that, make ketones, but breaking down fats for fuel for the body. So we have to focus on whatever it is the causative factor of that low bicarb, and that has to be where our attention is placed. I'm going to head over to the chat real quickly here and see if anybody has any questions. Nope, not looking that way. So let's get back to then our question number 6. So now you have a post-op abdominal surgery patient, and they've been putting out a copious amount of NG tube drainage, hint, 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 over the past several shifts. Which of the following ABGs would be most reflective of this? Give you just a few more seconds to figure that one out. Okay, let's go ahead and look at the answer here. So the key feature, and many of you got this, so kudos. The key feature here is the fact that this person has been putting out lots of NG tube drainage over the past several shifts. Maybe you'll get a story problem that says that the patient was diagnosed postoperatively with ileus. No matter how you're looking at it, we're getting a lot of stuff coming out of the GI tract, the stomach, right? So as we're sucking out all that gastric acid into the NG tube container, we're going to become alkalotic, right? So I would look for a pH, first of all, that is alkalotic. And so far, that's looking like 2 of them, right? It's looking like either B or C. So the next thing I say to myself is, okay, if I become alkalotic, am I going to become metabolically alkalotic, Or am I going to become alkalotic from a respiratory standpoint? And you can see here the reason why the patient becomes alkalotic is because of loss of metabolic acids. It has nothing to do with the respiratory system, but we'll talk about in just a second what an impact it has on the respiratory system. So what you can see here is B is the answer because the bicarb is elevated, right? We're becoming alkalotic. In C, the bicarb is just rock hard stable, okay, just the same. And that's a normal bicarb. Now look at the impact. As this patient becomes more and more and more metabolically alkalotic, take a look at the impact it has on the patient's ventilation. Because when you become metabolically alkalotic, you really rely on the respiratory tract in order to try and correct it. How does the respiratory system correct a metabolic alkalosis? By trying to accumulate acid. How do the lungs accumulate acid? By hypoventilating. So notice what's happening here. The PCO2 is going up and up and up. So this patient is retaining CO2 as a way of trying to compensate for the metabolic alkalosis. And so think this through, because as the patient hypoventilates, then that's going to have a really big impact on the patient's oxygenation status, is it not? All right, so B is the answer. Now we're going to head on over to question 7. And question 7 is just a general overall question about acidemia. Which of the following is true regarding acidemia? And keep in mind, acidemia is the clinical piece of paper or lab value or computer printout that says that the patient has acidosis plus clinical signs and symptoms. So when we add emia onto acidosis, so acidemia, it means that not only is it a lab value, but it actually is a whole clinical profile with signs and symptoms to go along with it. Take a moment and look this over, and I'll pull up the poll. Okay, guys, let me go ahead and pop up the answer. A is the answer, and most of you got A. Nice job. So acidemia, we're going to have decreased level of consciousness, decreased fibrillation threshold, which is defined as, the heart is more likely to fibrillate in an acidotic environment, and increase oxygen unloading to the tissues. So for number 7, A is our answer. So nice work. Let's look at question number 8. In which clinical situation would a metabolic acidosis with an increased anion gap be seen? Couple of seconds to finish up, and then we'll move on. All righty. And here's our answer. Nice work, everybody. Diabetic ketoacidosis. So here we have metabolic acidosis with increased anion gap. Now remember, from previous slides, we said that when you have a metabolic acidosis with an increased anion gap, the cause is acid gain. So you look at your answers here and you say, A through D, which one of these conditions cause acid gain? And the one that sticks out like a sore thumb is diabetic ketoacidosis. C. diff is going to cause profound diarrhea. You're going to have a lot of bicarbonate loss. severe vomiting, we just had that a couple of slides ago. We said that we're going to lose a whole lot of acid through severe vomiting or NG suctioning. So that wouldn't even apply because that would make us metabolically alkalotic. And then last but not least, pancreatic fistula. Pancreatic fistula is a whole lot of bicarbonate loss, causing us to become metabolically acidotic, but our anion gap would stay normal. So great job. Ketoacidosis, elevated anion gap, definitely. Question 9. The amount of oxygen dissolved in the plasma can be identified by looking at the okay. You guys are doing good. Couple more seconds and I'm going to bring up the answer. Partial pressure of oxygen, or PO2. Remember, the O2 saturation is the amount of oxygen and hemoglobin that are bound. Okay, so when we talk about PO2, we're talking about that 2%, the 2% of oxygen that's dissolved in the plasma. Great job. Okay, here's our last question for today, and that is, here's a patient's ABG, and what does this ABG best reflect? Couple more seconds, and I'm going to pull up the answer. Oh my gosh. Oh, that's kind of comical. I'm sorry about that, guys. I didn't have an answer slide here. So I needed to have an answer slide. And the answer is C, combined metabolic and respiratory acidosis. Because we see that the pH is low, the bicarb is low, which would make acid, but then take a look at the PCO2. The PCO2 is high, 66. So an example of a patient like this would be your shocky patient, somebody that looks like they need to be intubated and resuscitated. So combined metabolic and respiratory acidosis for this one. So nice work. It looks like everybody just about got that. So guys, just as a reminder to you all, I do have several things available to you to help you pass your PCCN or CCRN. I do have a 30 CE hour program for both of those courses, the CCRN and PCCN. The benefit of it is, unlike some of the others that are available, this is 24/7, 365 lifetime access. And so it's never going to shut off or go away. And as I update my programs, it will automatically upload to your curriculum. So as I make changes, it will be an automatic. There's also a mock exam at the end of all of these reviews and a printable CE certificate at the end as well. I also have CCRN questions of the day that I like to do via email. Again, I hope that you will encourage your friends to subscribe. By having been in the webinar, you're automatically on my email list. So again, if you'd help me promote, I'd really appreciate it. And also YouTube, if you would subscribe on YouTube, my goal in the next month is to get to 1,000 subscribers. And so if you could help me on that, that would be wonderful. I do have a special for attendees at my seminars, my webinars actually. And here's the code, which is today's date, 5/03/23, and then in all caps webinar. And if you go on my website and choose choose the online course that you'd like to purchase, you can put that in that code and receive $100 off. So that is a nice little perk for you for attending. So I'd like to thank you all for being here today. And in the chat, if you would be so kind as to tell me one takeaway that you're walking away with today, just one little pearl of wisdom, that would make my day. So thank you. I'm going to go to the chat and see what people are saying, what their pearls are. Confidence. That's nice. Any other pearls? Pearls of wisdom? Oh, you enjoyed. Thank you, Eileen. Eileen says she enjoyed the metabolic acidosis with and without an elevated anion gap. She thought that that was a good lesson. And then Phyllis really liked the understanding the oxyhemoglobin dissociation curve. And Nadine likes the confidence that she's walking away with after these times together. So excellent. Thank you so very much, everybody. And I hope you have a blessed day. I'll see you again soon. I will put out information as to when the next webinar will be via email. So thank you much, guys. And you have a blessed day. Bye-bye.